Hello friends, welcome all of you to my channel, and today we will be talking about cardiac tamponade. So before studying cardiac tamponade, we will start from a case. So see this case, this is 65 years male, has a valve replacement for mitral stenosis. So 65-year-old male was having mitral stenosis and he has valve replacement, and later after a few weeks she developed chest pain and she came to hospital. On examination it was found that the jugular venous pressure was elevated and the systolic blood pressure was 80 millimeter of mercury, and there was Pulsus paradox of 20 millimeter of mercury. And what might be the diagnosis of the female? So we will get back to this same case later. Now we will start the topic, and at last we will know how the female got this thing. Now the first question, what is cardiac tamponade? Cardiac tamponade is a serious medical emergency in which the blood or fluids fills in the pericardial space, that is the development of pericardial effusion, and the effusion fluid basically start to hamper the function of heart by compressing the heart. So this is basically cardiac tamponade, in which let's suppose this is the heart and this is a pericardium, and let's suppose this is a fluid around the pericardium, and this fluid is now compressing the heart. This fluid is now compressing the heart and compromising its function. So this condition, when the fluid is compromising the function of the heart, then we will call it cardiac tamponade. Then there is another question, that what amount of pressure is needed in order to hamper the function of heart. So the pressure created by the fluid should be around, so the pressure created by, so the intracardial pressure, pericardial pressure should be greater than 15 millimeter of mercury. So if the intrapericardial pressure, yani the pressure in the pericardial cavity, is greater than 50 millimeter of mercury, then the person will have the hamper the function. I mean the patient heart function will get deteriorated, and this condition is known as cardiac tamponade. So basically the cardiac tamponade to happen, there needs effusion. But you should know that all effusion do not lead to the cardiac tamponade. Only those effusion in which the pressure of the pericardial cavity is greater than, when exceeds greater than 50 millimeters mercury, then only the person will have the cardiac tamponade. The amount of fluid does not determine the cardiac tamponade will occur or not. The pressure will determine the cardiac tamponade will occur or not. So remember this point, key amount is not dependent. So let's take example. Let's suppose if any male is having pericardial effusion, if any male is having pericardial effusion, and let's suppose that he has a pericardial effusion for many years, and after 5-6 years he has a pericardial effusion of almost 2000 ml of fluid, then he may not have the cardiac tamponade. See, in this condition the male is having the pericardial effusion from a very long time, then it is a chronic pericardial effusion, and in case of chronic pericardial effusion there occurs some changes in the heart that the cardiac tamponade do not occur. So being the amount is very greater, I mean that is 2000 ml is very great amount, though it may not cause the cardiac tamponade. But sometime, let's suppose you have only 200 ml of the fluid, but it develops rapidly. So if very small amount of fluid, but if it develops very rapidly, then it may cause the cardiac tamponade. So you should know one thing, that the cardiac tamponade basically do not depend upon the amount of fluid. Basically it depends upon how rapidly the effusion is being formed. If the effusion occurs in a slow fashion, then the cardiac tamponade may not occur. But if the effusion occurs very slowly over years, then though the amount is very large, but the cardiac tamponade will not occur. So the same thing I have said here that the speed of accumulation of fluid determine the cardiac tamponade will occur or not. So rapidly developing pericardial effusion will lead, most probably will lead to cardiac tamponade, but slowly developing pericardial effusion may not lead to the cardiac tamponade. So this thing is very important point, and now we will see that how cardiac tamponade and what are the findings that occur in cardiac tamponade. Now if you have not understood anything in the definition, you will understand everything. Now we will talk in the pathophysiology in very great detail. So let's study the pathophysiology of the cardiac tamponade. We will start from a very normal concept that what happens in a normal person in case of inspiration and expiration. Whenever the person inhale air or exhale the air, what are the things that is happening in the heart in a normal person? First we will see that, then we will compare with that of the cardiac tamponade. So let's suppose this is a lungs and this is actually a heart of a normal person, and this you will see the veins. Basically this is the superior vena cava and this is the inferior vena cava. Now what I am telling, that let's suppose if any person is now is in inspiration. Let's suppose if any person is now in inspiration, it means the air is coming inside his lungs. Air is coming inside his lungs, and now lungs along with the whole chest wall get expanded. Lungs with the whole chest wall get expanded or stressed. So during inspiration we inhale more amount of air and the chest wall expanded. Whenever the chest wall expands, then what happens? The intrathoracic volume, that is the volume in the thorax, yani ki volume in the thoracic cavity basically increases. Volume in the thoracic cavity increases, and we know very good that volume is indirectly proportional to the pressure. That whenever the volume is increased, the pressure will decrease. That's why whenever a person inspire the amount of air, that's why in that time the chest expand, and whenever the chest expand, the intrathoracic volume increases, and whenever the intrathoracic volume increases, the intrathoracic pressure, that is ITP, intrathoracic pressure, this is decreases. The intrathoracic pressure decreases, and whenever there is a decreased amount of intrathoracic pressure, then what happens? The venous return to the heart increases, and the amount of blood that coming to the heart from the veins, basically the right heart, that increases during the inspiration. That's why during the inspiration the venous return to the right heart increases, yani the blood that is coming to the superior vena cava from superior vena cava or inferior vena cava increases during the inspiration. So we know that the amount of blood in the right side of the heart increased. Now when the amount of blood in the right side of the heart is increased, basically the amount of blood going to the right ventricle will also increased, and the right ventricle, when the amount of blood going to the right ventricle is increased, this extra amount of blood basically pushes the intraventricular septum, to the left side. What it will do? It will basically push this extra amount of blood that came in inspiration due to the negative pressure. All the blood is coming very rapidly to the right side of the heart, and the more amount of blood is in right heart. And whenever the more amount of blood is entering into the right atrium, then the more amount will go into the right ventricle, and this excess amount of blood that is going to the right ventricle will basically pushes the intraventricular septum and pushes to the left side, due to which the space in the left ventricle decreases. So what happens? The space in left ventricle decreases, and whenever the space in left ventricle decreases, then the amount of blood coming to the left ventricle, that is basically decreased. So if there is a less space in the left ventricle, then there will be less blood in left ventricle. So this is one thing. Another thing you should know that whenever the lung is expanding in the inspiration, that time the amount of blood coming from the pulmonary vein to to the heart the amount of blood coming from the pulmonary vein. Let's suppose this is the pulmonary vein, and the amount of blood that is coming from the pulmonary vein to heart also decreases. The amount of blood coming from the pulmonary vein to the left heart, any left atrium, also decreases as the chest wall expands. That's why the pulmonary vasculature also expands, and whenever the pulmonary vessels expand, then what happens, that the blood tries to remain in the pulmonary vessels for a period of time. That's why there is a less coming blood to the left atrium, and if there is a less blood coming to the left atrium, then this less blood will enter the left ventricle. So this is the second point. So there are two events happening. One event is the intrathoracic volume is increasing. This actually pushes more blood in the right side of the heart, and this more blood pushes the interventricular septum, and there is a space reduction in the space in the left ventricle. This is one phenomena. Another phenomena is that whenever the lung expands, then the pulmonary vessels also expand, and those vessels when expand, they will carry the blood in themselves for a period of time, due to which there is a less blood coming from the pulmonary vein to the left atrium. And if there is a less blood coming from the pulmonary vein to the left atrium, then there is a less blood going to the left ventricle, and due to which the total amount of blood in the left ventricle decreases. And whenever the total amount of blood in the left ventricle, so what happened, basically the left ventricle, the total amount of blood actually decreased, and if the blood in the left ventricle is decreased, then the left ventricle will pump less blood. That's why the cardiac output will be less, and that's why the blood pressure will be less, or we can say the blood pressure basically falls. So now during the inspiration, there is a less blood in left ventricle. That's why there is a less cardiac output, and there is a fall in blood pressure. So you make one sentence in mind that during inspiration there is a fall in blood pressure. So you should consider this in mind. There is a fall in blood pressure, and there is a fall in also the jugular venous pressure. So there is a fall in jugular venous pressure also, and there is a fall in blood pressure also. This is occurring during inspiration, and in the same way, during expiration, everything happens in opposite fashion. During the expiration, everything happens in opposite fashion, and there is actually slight increase in blood pressure during expiration. So similarly, as in inspiration the blood pressure falls, similarly in expiration the blood pressure rises. And that's why in a normal person, as a whole, in total, we could say that there is a very slight difference in the blood pressure during the inspiration and during the expiration. So there is a slight difference of blood pressure during the inspiration and during the expiration. So this actually fall in blood pressure, fall in BP during the inspiration is basically known as physiological drop in blood pressure. So this is known as physiological drop. Now we should understand that this physiological drop is basically in systolic blood pressure, and you should know that during the inspiration and expiration, the systolic drop is basically less than 10 millimeter of mercury, So that's why I mean to say that the fall in blood pressure during the inspiration in compared to the expiration is basically less. Normally it is less than 10 millimeter of mercury. But in some condition, in inspiration, instead of falling BP, so now we knew the normal event. Now we see then what happens in the cardiac tamponade during the inspiration. So what happens in cardiac tamponade basically, as the heart is basically, let's suppose this is the heart, this is above is atria and this is the ventricle, and let's suppose this is a interventricular septum. Now we should think that the fluids are around the heart, and these fluids basically are compressing the heart. So as the fluids are compressing the heart, but during the inspiration I said you that the more blood is coming to the right heart. See, during the inspiration the more blood are coming to the right side of the heart. As the more blood are coming to the right sided of the heart, then what happens? This blood is not now letting, see, whatever the blood comes, it actually pushes the right ventricle in all direction. Normally what was happening, that it was pushing in outside direction, in inside direction, and in the direction of interventricular septum also. But now what happens, as the fluid is outside the ventricle, that's why the blood cannot pushes the right ventricle towards the pericardial side, towards the outer side. It means it will push by more force to the interventricular side. So now the interventricular septum will actually displaced up from its normal position by a greater, more than previous. So normally also the interventricular septum was pushed to the left side, but now as the blood that comes during inspiration, that blood cannot push the ventricle, right ventricle, to the side of the pericardium. So it will push by more force the interventricular septum to the left side. That's why the left sided ventricle space is so much decreased in case of cardiac tamponade. That's why in cardiac tamponade, the left ventricle space is very much decreased. It is decreased more decreased than previous. Normally also it was decreasing, but now it is more decreased than the previous. Due to this condition, the fall in blood pressure is more than 10 millimeter of mercury. The fall in blood pressure is more than 10 millimeter of mercury. So this fall in the blood pressure during inspiration is basically more than 10 millimeter of mercury. This condition is known as Pulsus paradox. Pulsus paradox. So what is Pulsus paradox? Pulsus paradox is basically fall in the systolic blood pressure during the inspiration which is greater than 10 millimeter of mercury. Or we can say that Pulsus paradox is basically exaggerated drop in systolic blood pressure during inspiration. So during inspiration, the fall in blood pressure is exaggerated, that is greater than 10 millimeter of mercury. So that's why so why that is called Pulsus paradox? So simple reason is that if you will see the pulse of such a person, then you can see that the pulse will be present during the expiration, but the pulse will be absent during the inspiration. So pulse is like intermittent fashion. The pulse is present during the inspiration, the pulse is present during the expiration, but the pulse is absent during the inspiration. So this is called Pulsus paradox. Why the pulse is absent during the inspiration? As there is exaggerated systolic BP drop. And why there is exaggerated systolic BP drop? As there is exaggerated push of the blood to the interventricular septum to the left side, as the blood cannot push the ventricle to the side of the pericardium. That's why it is pushing to the opposite side in a more force, and that's why decreasing the more space of the left ventricle, and due to which the cardiac output is more decreased. And if there is a more cardiac output decrease, there is a more fall in blood pressure, and if it is greater than 10 millimeter of mercury, then there will be a very weak pulse or absent pulse. And this absent pulse or weak pulse is basically known as Pulsus paradox. So we can see that during the inspiration, the pulse basically disappear, and during the expiration, the pulse appear. And that's why the pulse nature is not fixed. That's why it is known as Pulsus paradox. So up to now, you got the two things in your mind. Then that there is a Pulsus paradox in cardiac tamponade. And you got another thing, that the blood pressure is basically decreased in case of cardiac tamponade. Blood pressure is decreased in case of cardiac tamponade. The blood pressure decrease not only in inspiration, the blood pressure is decreased in all time. Why the blood pressure decreased all time? Simple thing, you will see that the heart is surrounded by the fluid by all the sides. Then basically the right sided of the heart is, see, basically the right sided of the heart has a thinner walls, and the thinner walls are basically more pushed by the, more compressed by the fluid. And if they are more compressed by the fluid, then the blood incoming to the heart is basically decreased. The blood incoming to the heart is decreased, and as the blood coming to the heart is decreased, then the blood that will be sent outside the heart will also get decreased. And since the fluids are compressing the heart, and due to which there is a ventricular filling defect. There is a ventricular filling defect, as the ventricle will not get filled in a normal amount, and if there is a ventricular filling defect, then there will be decreased cardiac output. As there is a less blood, then they will pump out less, so there is a decreased cardiac output, and if there is decreased cardiac output, there is decreased blood pressure. And this blood pressure drops all the time. But yes, this is very natural that the blood pressure drops all the time, but the drop will be more exaggerated during the inspiration. Now let's study jugular venous pressure. So what happens in jugular venous pressure? So first of all, you should know that what is jugular venous pressure and why jugular venous pressure is given more emphasized in all the cases of heart. So why is so? Let's start. So let's suppose this is a heart, and let's suppose we have the superior vena cava, and this is a, let's suppose first of all, let's suppose this is a right, this is a brachiocephalic trunk. Let's suppose this is a brachiocephalic vein, and this is the right side, this is the left side, and we have the basically two veins going above. They are basically external jugular vein and internal jugular vein. The external jugular vein will is having the valve in them, but the internal jugular vein, from the right side of the heart to the internal jugular vein, there is no any veins, so no any valves. So I was mistake. So remember, there is no any valves in between internal jugular vein and right atrium. Since there is no any valve between the right atrium and internal jugular vein, so whatever the pressure will be in the right atrium, the same pressure will be in internal jugular vein. Whatever the pressure changes or blood hemodynamic changes that occurs in the right atrium, the same type of changes will occur in the internal jugular vein, as there is no valve between them. So if there is increased pressure here, you can say that there is increased pressure here. If there is a decreased pressure here, you can say there is decreased pressure in the internal jugular vein. So whatever the thing happens in the right atrium, the same thing we can say is happening in the internal jugular vein. As the right atrium cannot be accessed all the time from the external view, that's why we know the status of the right sided of the heart just by the internal jugular vein. So that's why in any kind of problem with the right atrium or right ventricle, we see that the internal jugular vein is alright or not. And the pressure that is present in the internal jugular vein is known as jugular venous pressure. So what is jugular venous pressure? It is a pressure that is seen in internal jugular vein. And why internal jugular vein is taken for the assessment of the right atrium? As there is no valve present between the internal jugular vein and the right atrium. Why not external jugular vein is taken? As there is a valve in external jugular vein, that's why it is not taken. So now when to know that the jugular venous pressure is elevated or the jugular venous pressure is decreased? So simply you should know that the right atrium is at the level of the sternal angle. So the sternal angle or the angle of Lewis is representing the right atrium, and that we will see basically the internal jugular vein pressure 3 cm above the sternal angle, 3 cm above sternal angle. So 3 cm above sternal angle, normally the jugular venous pressure or jugular venous pulse will be seen 3 cm above the sternal angle. But if it will be seen above the 3 cm from the sternal angle, then we will call that the jugular venous pressure is elevated. We will call the jugular venous pressure is elevated. So when we will call the jugular venous pressure is elevated, so what I said, कि normally the jugular venous pulse is seen 3 cm above the or within the 3 cm of sternal angle. But if it is greater than, if the jugular venous pulse is found greater than 3 cm of the sternal angle, then we will say that the jugular venous pressure is elevated. Now what happens in cardiac tamponade? Basically the heart is surrounded by the fluid from all the sides, and they are compressing the heart, and they are compressing these vessels also. These fluids are basically compressing these vessels also. And whenever these vessels get compressed, the blood coming from the basically the veins is actually cannot come in a good fashion, or it is difficult for the blood to come into the right sided or in the right atrium, as the blood as there is a compression of the basically the right sided, as the right side has thin walls, so there is actually decreased space in the right side, and as there is a decreased space in the right side, there is a more pressure. We can tell that the pressure in the right side is increased, and I said you whatever changes is seen in the right side will be same changes will be seen in the jugular vein also. That's why if there is a more pressure in the right side of the heart due to the compression from the fluid, then the same pressure, elevated pressure will be seen in the jugular vein also. That's why the jugular vein pulse will be now felt above the 3 cm, as there is a more pressure in the right atrium, so the blood coming to the right atrium is also have a somehow resistance, and due to which there is a more actually pressure in the jugular vein also, internal jugular vein also, and the internal jugular vein is distended, and that's why in cardiac tamponade there is a elevated jugular venous pressure. So you should consider this in mind, that in the cardiac tamponade the jugular venous pressure is elevated. So up to now there is a three things we saw. Up to now there are three things we saw in case of cardiac tamponade, that there was the decreased blood pressure, there was basically Pulsus paradox, and there was elevated jugular venous pressure. So these three things you understood from the cardiac tamponade. Let's now see some waves of the jugular venous pressure. So I said you that whatever the pressure changes in the right atrium, the same pressure changes will be in the internal jugular vein also. So let's suppose the heart is contracting, and let's suppose the atria is contracting first. So due to atrial contraction, basically there is a wave formation. This wave is known as A wave. So basically this A wave is denoting the atrial contraction, and whenever there is atrial contraction, then what happens? All the bloods of the atria totally goes into the right ventricle, and now the atria start to relax. So so initially the atria was contracting, that's why the pressure is actually increased and it reaches its peak, and now the atria start to relax and the pressure is decreasing. But meanwhile the pressure is decreasing for a point, then what happens? Ventricles start to contract, and when ventricles start to contract, there is a valve, we know that tricuspid valve. So there is a valve, this is valve, let's suppose tricuspid valve. Due to the ventricle contraction, the tricuspid valve closes, and whenever the tricuspid valve closes, for instant there will be increase in the atrial pressure due to the valve closure. So again there will be increased pressure, and this wave is known as C wave. So what is C wave? C wave is basically tricuspid closure. Tricuspid closure. And now the atria is still relaxing, so the pressure drops. And now what happens? So pressure is dropping, and whenever the heart is relaxing, then for a point of time the blood is coming to the heart, right atrium, but that incoming blood do not increases the pressure in the right atrium, but there comes a point after which the incoming blood is more, and due to the more incoming blood, now the incoming blood causes the increase in the pressure of the heart, right atrium, and due to which again the pressure get increased, and this forms the V wave. So this V wave is basically due to the atrial filling, and again at a point of time the tricuspid valve after a point opens, and again there will be descent, and this descent is basically due to the tricuspid opening, and all the blood going to the ventricles. So this is a wave formed from the internal jugular venous pressure. This is a wave, A wave, C wave, V wave, and we can see that there will be A wave. So A wave was due to the atrial contraction. Now there is a drop. This drop is due to atrial relaxation, but meanwhile the atria was relaxing, there was tricuspid closure, due to which there C wave formed, and once the C wave is formed, then the atria was still relaxing, that's why the pressure goes down, and again once the filling is more in the atria, the pressure in the atria again rises. This is V wave, and again whenever tricuspid valve opens, all the blood goes into the right ventricle, and the pressure again drops down. So there are basically two descents in case of the jugular venous pressure wave. So one descent is this descent, and one descent is this descent. So this descent in the pressure, this descent is known as X descent, and this descent is known as Y descent. So basically there are two descent in the pressure of the jugular vein, that there is X descent and Y descent. X descent was due to the atrial relaxation, and the Y descent was due to the tricuspid opening and the release of atrial pressure. What happens in cardiac tamponade? As we know, the right ventricle space is decreased. As we know, in the cardiac tamponade, due to the pressure of the fluid, the right ventricle space is decreased. So the blood that should come into the right ventricle cannot come properly, and the more amount of blood goes reverse back into the jugular vein, and the more amount of blood due to the atrial contraction goes reverse back into the jugular vein, and due to this there is an improper filling, and though there will be the tricuspid opening, but the blood cannot go into the right ventricle in a good way, as there is a less space and as there is a compression, due to which there will be Y descent. The Y descent will get lost, as there is the pressure inside the right atrium is not decreased, as the blood is not going in a normal amount into the right ventricle. That's why the Y descent will be lost. So that's why you will see that there will be loss Y descent lost in case of cardiac tamponade. So why there is a Y descent loss? The reason is that there is improper filling of the right ventricle due to the pressure around the heart, and due to this the blood get reversed back into the jugular vein, and due to this the jugular vein pressure is elevated. So there are two things: elevated jugular venous pressure, and there will be the descent of the, there is a loss of descent of the loss of Y descent. So normal jugular venous pressure was like this. So this is a A, C, this is a V wave, and this was the X descent and this was the Y descent. So this was a normal. This was the normal. But what happens that the jugular venous, one thing is JVP is elevated. JVP is elevated. And another thing was that the wave will not be like this. The wave will be like this now. So you can see the Y descent is lost. Y descent is lost. Why Y descent is lost? As there is an improper arterial emptying. As there is improper arterial emptying, as there is less space in the right, improper right arterial emptying, as there is a less space in the right ventricle. Less space in right ventricle. So this was a little bit tougher, I think, but I think I have tried well to make you understand. Hope you understand. If you do not understand, if anything in this topic, you can just text me or write in the comment section. I will let you know. One thing I want to say you that the same thing I have told in the case of the pericardial effusion, that there is a fluid around the heart, and whatever the current that the heart produces, due to it has to cover a large distance, and due to which the amount of let's suppose this is the electrode, and this electrode is basically catching the current of the heart. But as there is a fluid around the heart, the current has to pass a large distance from the normal person in comparison to the normal person, and that's why there is a less voltage reaching the electrode. That's why the ECG will be having the low voltage. This is the first thing. And the thing, if you put a stethoscope around the chest, then the heart sound will be muffled, or heart sound will be of low tone. Why there is a low tone or muffled heart sound? As the heart sounds produced from here has to travel a lot of distance, or has to travel the resistance of the fluid around the heart, and then only it can reach to your stethoscope. That's why on auscultation there is a muffled heart sound, muffled S1 and S2 heart sound. So muffled lob dub sound, or this is known as a low lob dub sound or low heart sound. So muffled S1 and S2. So these are the things will be seen in case of pericardial effusion or in case of cardiac tamponade. So basically the diagnosis is mediated by the, first of all, the echocardiography. Echocardiography. Basically the echocardiography is useful if the fluid amount is greater than 50 ml. And now another investigation we have the chest X-ray. But the chest X-ray is useful when the fluid is greater than 200 ml. So let's suppose if any person is having the fluid between 50 to 200 ml, then which is an investigation of choice? The simple answer is echocardiography. But if the fluid is greater than 200 ml, then what is the investigation of choice? Then also echocardiography. But yes, if greater than 200 ml, if the fluid in the pericardial cavity is greater than 200 ml, then yes, the finding will be greater in chest X-ray also. So you can take the help of chest X-ray. Third thing that ECG gonna help you to tell about the pericardial effusion. So let's study all things in detail. In diagnosis, let's talk about the ECG first. So ECG is my favorite part. So let's talk about ECG. So first of all, you have to know that from a normal heart, what is the difference in the pericardial effusion? So let's suppose this is a heart, and around this heart, this is a layer of the pericardium, and we have the effusion. We have this effusion. So this is a fluid, and now with whatever the electrical activity is produced in the heart has to travel a lot of the distance, and then only it can reach the electrode. Let's suppose this is the electrode, and this electrode is catching the current produced by heart, and it is producing the ECG in response to that. But what is the difference from the normal person? The normal person heart has, when the normal person heart produces the current, it has not to travel, it hasn't to travel this extra distance. In that, basically the due to the fluid present around the heart, the electrical activity, whatever the produce in the heart, has to travel extra distance of this pericardium and the fluid, due to which there will be very less voltage less current reaching the electrode, due to which in ECG, whenever we will see the low voltage ECG. We will see the low voltage ECG. So what is the reason behind low voltage ECG? Very simple. There is so much of the fluid around the heart, and due to which the electrical activity, whatever is produced, has to travel a more distance to reach electrode in comparison to the normal person. That is why whatever the voltage reaches the ECG is low, and due to which the ECG is low voltage ECG. Then how to know the voltage of the ECG is low? It's very simple. If there is a low voltage ECG, you will see that the amplitude of every wave, so let's suppose this is a P, this is a QRS, and this is a T, then in the low voltage ECG, you will see the very less amplitude of like this. So this is basically low voltage ECG. Low voltage ECG. As you can see from the normal ECG, it is different. That is each amplitude has decreased. But remember, low voltage ECG has no problem in duration. No problem in duration. In the duration of the waves, like the P wave, duration of the P wave, the duration of QRS, or duration of the PR segment, there will no any problem at all. But yes, what will be the main problem? The problem will be the amplitude of the waves get decreased, and this is the thing how we're gonna know about the low voltage ECG. Now let's talk about another things in the ECG. Now we all know that the QRS wave is produced, whatever the QRS wave is produced due to the ventricular depolarization. So the QRS wave is basically produced to the ventricular depolarization, and let me show you. This is the main vector that actually produces the QRS wave. This is the main vector that produces the QRS wave. So normally a normal person QRS actually do not vary in ECG. The amplitude of QRS remains constant in ECG. So let's see a normal ECG. So what we will see in normal ECG. So let's first talk about normal. Always first talk about the normal. So let's suppose that I'm talking about normal. So QRS and T, again the P and QRS and T, again we have normal and the QRS and T. So see, the amplitude of the QRS is same in every step, but what happens in a pericardial effusion, that the heart is now in such a space, there is a fluid around the heart, and now whenever the heart is contracting, or whenever it is producing any current, the heart is basically moving. So whenever the heart moves, so let's suppose I have placed an electrode at this point. Let's suppose I have placed an electrode. Let's suppose this is an electrode, and it is actually catching the current. It is actually catching the current produced by the ventricular depolarization. Let's suppose this is an electrode, and it is catching the current produced by the ventricular depolarization. Since there is so much fluid around the heart, now the heart actually moves. Now the heart has a very free space to move, and now it will feel like it is in swimming pool. The heart will feel I am in swimming pool. I am in swimming pool. So what you will do in swimming pool? You will actually move here and there. So the heart will also change its position. It will move here and there, and due to the changing its position from here and there, what will happen? This major ventricular waves that produces QRS wave, this wave is also not fixed. Sometime when the heart moves here, the wave will go here. When the heart moves more far, the wave will go far. And when the heart again comes near, then the wave will go more nearer. I mean to say that the amount of the current reaching the electrode will not be same, especially in case of the ventricular depolarization. As the major ventricular waves, especially they fluctuate, the wave of the QRS wave, that's why fluctuate in case of the pericardial effusion. Reason is the heart position is not constant. The heart is constantly changing its position as it is in swimming pool. It is constantly moving or dangling here and there, and due to which there will be fluctuation of the current reaching the electrode. That's why there will be the fluctuation in QRS amplitude. There will be the fluctuation in QRS amplitude, and this fluctuation in QRS amplitude is known as electrical alternans. So what is electrical alternans? Electrical alternans is basically the fluctuation in QRS complex or QRS wave amplitude. Reason is that the heart is not in a constant place. It is moving at every time it's contract, and due to its movement, the wave or the current going to the electrode is also not constant, and that's why the current reaching the electrode, as it is not constant, that's why the wave formed by the electrode or the ECG QRS wave formed by the electrode is also not constant. That's why there is a variation in the QRS wave. So let's see the ECG now. So in ECG you will see like this. So let's suppose this is a QRS and this T, and let's suppose another QRS is very very big, and then T again, some QRS is very so this is a you can see some QRS is very large, some is small, some is medium. So that type of thing you will see in case of the pericardial effusion. So in ECG we see the two things. One of the thing was that there will be low voltage ECG, and another thing was, please whatever I say write down please. And another thing was there was electrical alternance. As we know, the pericardial effusion, if there is a pericardial effusion, then the person may have the pericardial tamponade, that the heart function may be compromised due to the excessive amount of fluid, and that's why the pericardial effusion may lead to pericardial tamponade. I mean cardiac tamponade, may lead to cardiac tamponade. That is, the fluid will compress the heart now. And there will be more extra findings of the cardiac tamponade also, but that we will discuss in the cardiac tamponade part. From here, I want just to tell you that in cardiac tamponade also you will see the low voltage ECG and you will see the electrical alternance. So in that time I will not tell how the low voltage ECG and electrical alternance will develop, but you should know that yes, these two things develop in case of cardiac tamponade also. Hello guys, welcome back, and now let's see again the chest X-ray. So chest X-ray. So let's talk about, so chest X-ray will show you the signs of the pericardial effusion if it is greater than 200 ml. So let's see. This is a lung. And let's suppose this is a heart. This is a normal heart, and we have, let's suppose this is some artery veins going to the heart. So this is a normal ECG. What happens in case of the pericardial effusion? That in this space you will see the cardiac shadow. So in this space you will see that this is actually cardiac shadow, or we will also say this cardiac silhouette. Okay, so this is cardiac shadow or cardiac silhouette. And now what happens in case of the pericardial effusion? Due to the pericardial effusion, the cardiac shadow has increased. Basically, the cardiac shadow has increased, and now this appears like a water bottle like this. See, it appears like the water bottle. So that's why due to the increased cardiac shadow or cardiac silhouette, Okay, due to increased cardiac, it appears like the water bottle appearance. Water bottle appearance. And the thing, we will also call it as a money bag appearance. So this is also known as money bag appearance. Money bag appearance. And you can easily see the cardiothoracic ratio has increased. Normally this cardiothoracic ratio is yani ki the ratio between the heart shadow and the total thorax shadow is less than 50%. Yani normal this heart is the shadow of the heart is less than 50% of the total shadow. So there will be increase in cardiothoracic ratio. So cardiothoracic ratio is increased. So these are the findings you will get in the chest X-ray of the pericardial effusion. Hey, welcome back. Now we will see the Beck's triad. So Beck's triad is basically the gist of the cardiac tamponade. It is the heart of the cardiac tamponade. So let's suppose if there is these three things, then it is surely certain the patient of the cardiac tamponade. So what are those things that are the components of Beck's triad? So one thing is the muffled heart sound. So we have already studied muffled S1 and S2. There's a muffled heart sound, that is a decreased heart sound. Another thing, there is a elevated jugular venous pressure. Elevated jugular venous pressure. And the third thing is that there was the decreased blood pressure. So elevated jugular venous pressure, decreased blood pressure, and muffled S1 and S2. These three things comprises of the Beck's triad. And yes, the fourth thing is Pulsus paradox, which you will not forget. The fourth thing was the Pulsus paradox. And I have already discussed about everything in a very great detail, I think. Now there is a question that how will you differentiate the pericardial effusion and cardiac tamponade? So how will you differentiate the patient is now only having pericardial effusion, or now he has gone into the cardiac tamponade? So very simple. There are many methods, but I will tell you. In ECG, if you will see the electrical alternans, then this is actually confusing thing, as the electrical alternans is seen in the pericardial effusion, is also seen in the cardiac tamponade. But if there is a electrical alternans plus Pulsus paradox, then this is surely cardiac tamponade. So if there is a electrical alternans plus Pulsus paradox and jugular venous pressure elevated, then it is a case of cardiac tamponade. But if the person is only having the electrical alternans, then the person is of the pericardial effusion. So keep this thing in mind, that the person is only having the electrical alternans, the person is cardiac effusion. But if the person is having the electrical alternans plus Pulsus paradox, then the person is having the cardiac tamponade. So by this you can differentiate between the two. And there's one more thing in case of the cardiac tamponade, that there is a sinus tachycardia. So why there is sinus tachycardia? As the blood pressure is falling, so whenever the blood pressure falls, there is a sympathetic response, and due to this sympathetic reflex, what happens? It leads to the increase in heart rate. So that is sinus tachycardia. So there will be the heart rate increased in case of the person with the cardiac tamponade. Now let's see the case that we discussed in first, that there was 65 years male who was having the mitral stenosis, and he was having the operation of that. He was having the valve replacement operation, and after operation he developed the chest pain, and then he came to hospital, and I said you there was on examination, there was the elevated jugular venous pressure, there was the systolic blood pressure of 80 millimeter of mercury, and there is a Pulsus paradox of almost greater than 20 millimeter of mercury. I said you that the Pulsus paradox can be more, in normal person it can be less than 10 mm of mercury. So if there is a difference in the pulse in the expiration and inspiration, can be 10 millimeter of mercury, but if there is a greater than 10 millimeter of mercury, and see there is a jugular venous pressure, a raised JVP, there is a pulsus paradox, and he is telling about the chest pain. So what might be happen that during the operation he might get the infection, and the infection may cause the acute pericarditis, and due to the acute pericarditis it leads to the pericardial effusion, and due to the effusion it might actually raise the intrapericardial pressure. It might raise the intrapericardial pressure, and when intracardial pressure was raised, then the cardiac tamponade was happening, and that's why the jugular venous pressure was raised. The pulsus paradox was greater than 20 millimeter of mercury. Systolic blood pressure anemic is 80. It means that the systolic blood pressure is false, and this all condition is showing the person is having the cardiac tamponade. So very simple to diagnose the patient now. And we also say that in this patient there was increased heart rate. On examination there was muffled heart sound. So I think you got to know this about this case very clearly.